I'm chairing today's Health and Wellbeing Board meeting. Given the departure of Professor Sir Jonathan Montgomery as chair of OUH, the board does not currently have a vice chair. Once a new chair of OUH is recruited, they will become the new vice chair of the Health and Wellbeing Board. Please note that the all-age autism strategy has been postponed until our July meeting. This is to allow the strategy to be discussed at the Health Overview and Scrutiny Committee prior to its formal sign-off by the Health and Wellbeing Board. We do have a neighbourhood health plan item at this meeting. This is for the purpose of us noting the ongoing work to develop the plan, as opposed to signing off a final version of the plan, because that's not quite ready yet. Another point to note is that there's a proposal that we revert to having four public meetings of the board per year, as opposed to the current 5. The purpose of that would be to allow for a 5th meeting to take place, but more in an informal workshop style, which would not be in public, so that we could examine and discuss key developments in a bit more depth. And finally, in order to accommodate our external guest, Professor Erica Charters from Oxford University, item 6 on the agenda, I think it is, around Community Health Development Officer, the Community Health Development Officer item will be moved to later on the agenda towards the end of the meeting. I do plan to have a short break roughly halfway through the meeting, depending on how we're doing for time. Okay, so item 2 then is apologies for absence and any temporary appointments. We've received apologies from Councillor Kate Gregory, from ANSAF, for whom Kate is standing in, and apologies from Matthew Tate, with Chris Wright substituting to represent the Thames Valley ICB. Do we have any others? Item 3 then, declarations of interest. Do any members of the board have any interests to declare? No. Okay. Item 4 then is petitions and public address. Councillor Jane Hanna, who is chair of the Joint Health Overview and Scrutiny Committee, would like to address the board in relation to items 6, 7, 8 and 9. Usually there's a speaker limit on this section of 3 minutes, but because of the number of items, I've agreed that Jane should have the maximum 5 minutes. So please, Jane, could you address us now?
Thank you, Councillor Fawcett, and of course HOSC hasn't convened as a committee yet in terms of actually appointing a chair, so I'm going to speak very much as a local member, but reflecting on the work of scrutiny over the last year and how it relates to the papers. Just wanted to say I thought it was really good to see through the papers the progress that's been made through collaboration of partners since I became a councillor in 2018. And collaboration is the most difficult thing to do, but absolutely crucial for our residents at the moment, because it's only through that we get best value for our residents. And so that has been a real theme of HOSC, to really really press that message that we know you're all trying really hard to do, and just to say, keep doing it. I wanted to mention agenda item 6 in relation to, we absolutely support the approach, the grassroots approach, the approach working with communities, understanding the local ecosystem and how to build resilience of communities for maximised values. And that it's essential that there's no regression in the most deprived districts. I just want to urge the board really to reflect going forward on how can an Oxfordshire-wide ambition be included to reflect rural areas like the Vale, which has seen a decline in it's the only district that's seen a decline in its multiples of deprivation. And also all the rural areas which have seen dramatic shifts in terms of housing, huge issues of access to health and problems with transport. And, in that regard, there is a recommendation that was accepted by HOSC, from HOSC, which was about how could some offer being made, appreciating all the finance constraints that there are, but is there something that can be offered to support the capability of rural communities to connect with local members in local communities, the parish councils, the whole ecosystem of grassroots organisations, and how that work often it's just really critical to be recognised, so that, you know, how could that sort of happen sort of going forward, and taking account of the work in all the other areas. And in relation to that, I did want to speak about the Better Care Fund, that the new NHS target, which is now to reduce the end of life patients in hospital to 10%. It's just reflecting with that national target, you know, how will that play out in terms of areas like mine, where there are no local beds and there's no local palliative care offer. And it's something which is therefore really difficult, you know, for an organisation that is tasked with meeting targets. And the county council has done brilliantly with the Oxfordshire Way, but this is another sort of target on top. And it's sort of really to end things. It's really about, I suppose, sharing my reflection on the papers, which is that we've got that bottom-up approach from public health, which is taking uncertainty, taking an approach to actually work and journey with communities, using different forms of evidence to reference your progress, achieving meaningful change with that type of approach. How do you reconcile that with approaches that will be highly centralized and national and focused on targets? How does a local system with all the people, leaders all around the room, work together in a way that sort of keeps our residents always as the focus, so that we can actually make meaningful change and offer hope to every resident and every community across Oxfordshire, even if we can't do intensive bits of work across every single part of the county. So thank you for listening to me, and thank you for all the work you're doing.
Thank you, Jane. Those very helpful comments, and thank you to you too for all the work you do as chair of HOSC. Right, so item 5 then is minutes of the previous meeting, where we're asked to approve the note of the decisions made at the last meeting on the 12th of March and to receive any information arising from them. Can I first of all check, for those of you who were at that meeting, whether you've got any points to raise on the minutes? No? Okay, so can we note the minutes? Yep, thank you. Are there any matters arising from them? No, good. This is the kind of meeting I like. Items. So for those of you who arrived slightly late, we've already said we would be moving item 6 to later in the agenda, so that our guest will be available for that item, which means we now go on to item 7, the Oxfordshire Joint Strategic Needs Assessment 2026, which I'm expecting Craig Miles-Clark to lead on.
Thank you, Councillor Fawcett. Hi there, everyone. Can you hear me?
Yes.
Excellent. I'm just going to share my presentation. Hope that everyone can see this. Is that visible to everybody in the room and everyone online?
I can see it, thank you.
Okay, so good afternoon, everybody. My name's Craig Miles-Clark. I'm a Senior Research Officer here at Oxfordshire County Council and a member of the Data Office team. Last year I was responsible for leading the 2025 JSNA, and this year I've put together the proposal for the 2026 JSNA for the purposes of the Health and Wellbeing Board. So I'm approaching today's presentation with a view that you've read the paper already, but obviously want to pick out a few highlights and then provide an opportunity for questions at the end. So first of all, I want to talk about help and resources that we've added to the JSNA since the last meeting, reflecting on some recent user feedback that we've had for the JSNA. then talk in a little bit more depth about the proposal for the 2026 update and the next steps that will be attached to that. And then, as I said, some time at the end for questions and comments on the paper and the JSNA more broadly. So first things first, help and resources. So we've led training sessions for the JSNA across multiple teams at Oxfordshire County Council. Alongside that, we've produced 3 public-facing videos which are available via the Oxfordshire Data Hub. They talk about some key functionality of the JSNA, specifically the Power BI dashboards that we've added in recent times, so that we can sort of proactively meet user need and hopefully allow users to self-serve when using the JSNA online. Moving on to user feedback. So we recently conducted a survey to both reflect on the way that the 2025 iteration had been received, with a view to then using that research to inform the design of the 2026 JSNA. So as it says here, the majority of users feel confident navigating the JSNA and prefer the new blended format, which to clarify means that we have interactive Power BI dashboards, and we also retain the statics or PDF documents which contain a narrative report which consolidates the data and research within the JSNA. And to sort of provide a bit more detail there, the users also felt that the data was easy to find as part of this new format. On accessibility, most respondents reported that JSNA was accessible to them, and then just 3 respondents reporting a negative sentiment about the ease of use of the new format. And we continue to work to ensure that the JSNA is compliant with the relevant accessibility legislation and guidance. Point 3 here, so despite what I said about our recent update around help and resources, which came sort of between whilst doing this user survey, some people did have mixed feelings about training, so this provides a point of reflection for the team. From the internal training offer, it was clear that we had some strengths to our sort of training sessions that we provided, but clearly there's room for improvement. So that's something we'll revisit as part of the 2026 offer and rollout for the JSNA. So for the 2026 update and proposed additions, so we intend to present it via interactive Power BI dashboards alongside the analysis and narrative reports for each chapter and its associated themes, as we have done for this year. The latter will be available in downloadable PDFs, and the Council hopes to continue to leverage the benefits of the digital tools while retaining the rich narrative that explains the findings of the JSNA. We'll seek input from the JSNA steering group to decide on the content for the new edition. As a starting point, we'll review the data and research that was included in the previous edition, which included a total of 435 indicators. For additional requests, we'll prioritise those based on their public health needs, strategic alignment and developer capacity. And just a note here that given Oxfordshire's status as a marketplace, the JSNA obviously has an important role to play in furthering understanding of the health inequalities in the county, and the steering group will be considering those as part of their work. I've brought 3 specific proposals to highlight in the board meeting today. Those are inclusion health groups. So as it says here, this would constitute a complete update of the data and research that was included in the 2024 edition of the JSNA and a more complete summary of this research, the data and research therein. Further data and research related to homes and health, and we've been shown some work that Hertfordshire have done around their healthy and safe places model as a starting point. And then gambling harms, again, this was included in the 2024 JSNA. We didn't update it as part of 2025, but the proposal is to do so for this next edition. For next steps, so obviously today we are proposing the new JSNA. Following that, we will aim to re-engage the steering group, so with representatives from partners of the Health and Wellbeing Board and other relevant stakeholders. So obviously this will ensure that the group involves and reflects the needs of residents, patients and partners across Oxfordshire. In the first instance, we'll contact members of last year's board, but as part of today and indeed sort of in the coming weeks, additional group members continue to be sought to ensure that obviously that that group reflects, can provide the most up-to-date information and sort of surface the needs that need to go into the JSNA. That then means that the JSNA 2026 development begins proper, and I've hopefully illustrated there that sort of cyclical relationship between the development of the JSNA and ongoing engagement with the steering group. So that will happen several times throughout the course of its development to ensure that it continues to be in line with steering group expectations. The JSNA reflects the health and wellbeing needs of the population and obviously meets expectations for both the group and the board. And then following that, user testing of the digital JSNA will be taken upon completion of each chapter. And again, that cyclical process there with ongoing development, user testing and such to ensure that what we produce is robust and in line with expectations, with final board approval expected towards the end of the year. And a point of reflection, I think we want to make sure that we produce a more robust communications plan this year, and so we'll intend to do that towards the end of the development of the JSNA to ensure that key findings are shared and awareness of the JSNA is raised across the council and our partners. So that's everything that I wanted to share from the paper. So with what time's left, I'm obviously open to field questions and obviously take on any comments and such from the board for the development of the next edition of the JSNA. Thank you.
Thanks very much. Does anyone have any questions or comments that they would like to make? Chris.
Thanks, Craig. Yeah, just wanted to say thank you for the work that went into the JSNA last year was part of that process, and I think it was very well executed. And also the wider data hub hosted by the county council is certainly very useful from a NHS and healthcare capacity, and I'm sure there are lots of members of public and our residents that find it interesting as well. So thank you.
Thank you, Chris.
Thank you. Anyone else? Michelle.
Yes, no, thank you. Just really wanted to echo the feedback that Chris has been given. That sounds a bit echoey, sorry. But yes, I've used the dashboard quite a lot recently as part of the neighbourhood work, so would echo how useful it is. So thank you.
Thank you, Michelle.
Yeah, thanks. Apologies. It is a bit echoey in here. Would anyone else like? Yes.
Yes, to reiterate the same, and really pleased to see the local research chapter still there in the plans. I just wondered how it's going to tie into the community research network as well across, because there's a lot of community-based research coming up, which needs to be captured in that qualitative side of things.
Yeah, that's right. And it was raised as a point in the survey feedback, actually, that rather than have this potentially sitting in sort of disparate places, that the JSNA could, given that we have the local research chapter, that could become almost like a living repository of that kind of work. So that's something that we'd be keen to speak to colleagues about and understand what that need is and whether that's something the JSNA could work to meet. So yeah, we'd be absolutely be open to that.
Thank you. Any other questions or comments? No? Okay, so we were recommended to provide feedback on the proposed design of the 2026 Joint Strategic Needs Assessment, advise on the content of the 2026 JSNA approach, and to highlight any additional topics and themes of research and intelligence interests that we would like to see included, and via relevant officers in our organisations contribute information and intelligence to the JSNA to further its development and participate in making information more accessible to everyone. We've obviously started to do that in this discussion, but I'd encourage everyone to continue to engage with the process going forward, and thank Craig very much for his presentation and his team's work on this. Is the board happy to agree those recommendations? Yes, thank you.
Thanks, Councillor Fawcett. Thank you, everybody.
Thanks. Right, item 8 then is the health and wellbeing strategy update. Start well, and I'm expecting Lisa and Annette to lead us off on this, and Councillor Gall.
Yeah, so just thank you, Councillor Fawcett. So just a quick intro from me, and then I'll let officers do the real hard work, which is explain it. So this is really exciting, actually. So for a number of meetings that I've sat through on the Health and Wellbeing Board, we've been speaking about good level of development. We've been speaking about the inequality or the huge gap between the children that are eligible for free school meals, currently achieving 43% good level of development, and then all the children combined, which is close to 70%. The inequality at the moment is close to 30%. We had a target set for us by government that was going to increase the good level of development for all of our 5-year-olds. If they achieve good level of development, what happens is they are ready to learn when they get to primary school. So it's a huge moment. And if we'd have achieved the government's targets, we'd have notched off just 2% off the inequality. We would have improved it for everybody, but we wouldn't have done enough on the inequality. And, you know, with the help of Lisa and Annette and many others, we've set about a local revised target that will really drive inroads into this. And we've been very, very ambitious. And we are now going to set ourselves fresh targets that will supersede the government's targets. And if we are successful, we will be successful because that's exactly the work that we're setting about now. We will close the inequality from 30% to 20%. I don't think we'll be totally thrilled that there will still be an inequality of 20%, but to take a third of that will be absolutely huge. It will impact an awful lot of our children across the county. Everybody will be able to take great pride in having achieved this. And the work that's underway right now is we're putting together a plan that will be as robust and as effective as possible. And within this, we'll be asking for permission from all of us from this board, that the Children's Trust Board that I chair will be given the responsibility of seeing this through, bringing together the key partners, the key movers and shakers that will help to turn this into a success. And my intention is to use that as a safe space to make sure that we've got everything that we need, that everybody's got everything that they need to be as successful as possible, because this is going to be absolutely massive when we pull this off. So I'll let Annette and Lisa and others talk us through the detail of it. But, you know, this isn't a regular report. This isn't a regular update. This is absolutely huge for our very youngest in the county, and this is really, really exciting. Thank you.
Thank you, Councillor Goll. Lisa?
So I won't add too much because it's quite a lengthy report. You'll see that there's quite a lot of things that are having some success and things that are still in progress. But I just wanted to say that there's an awful lot of government reform and change in this space. So we're trying to cover everything around the Family First reforms, the SEND reforms, the anti-poverty strategies that are coming in, the change in the white paper for schools, the targets that are set for, as you said, Councillor Gould, good level of development, school readiness, child development, the work in health and emotional health and wellbeing across the council, and then Best Start in Life, of which the plan that was required to be published on the 31st of March is an appendix, and also the Family Hub rollout and the Youth Hub rollout. So there's quite a lot wrapped up in here. And I'll introduce, if you haven't met Councillor Fawcett, Annette, who is the SRO for this project, as the Deputy Director for Education and Inclusion, leads on Best Start in Life and also leads on good level of development, early years education and so on. And I think we'll open up for questions because I hope the content is sort of self-explanatory, really.
Thank you. Is there anything you want to add to that at this point, Annette?
Just that we're really excited, actually, about this plan. We all know early years education is so important, and it feels like there's an appropriate and right focus on it for the first time, which we think is great. And also the fact that we're a Marmot County, and one of the first deep dives was into early development of children has been really helpful. So we're utilising, as Lisa said, all the sort of the energy around national reforms to bring us into a joint space by working together.
Thank you very much. Does anyone have any questions or comments that they would like to make? I do, but I'll let other people go first. Kate.
Hi, yeah. Thank you for the report and your really inspiring call to action introduction. it's great to see all of this work and that commitment to reducing the gap in health equity. And, you know, I'd just like to reiterate our commitment to making sure that we're bringing together all of those wider determinants of health to this plan. So obviously you're very focused specifically on the children's side, but there are other aspects that we can really support this with, and we'll work closely with you to do that.
Thank you. Yes.
I was just wondering, you know, about the family hubs and how families in rural areas will be able to access the services provided by family hubs.
So the plan is to have 5 district hubs, but also to have satellite opportunities and what we would call pop-up hubs. Sorry, it's a bit echoey. Try not to be too loud. So there is a plan that we will be using satellites into those rural communities, so families in those rural communities can access them, but we'll also be extending our use of VCSE colleagues and partners, using faith organisations. So what is already utilising what is already there and working in a different way through what is already there as part of the community, and where we need to strengthen that. Step into that space and strengthen it. So we have considered our rural communities as well.
Lisa.
So also as part of the Family Hubs rollout, there's a requirement for a complete overhaul of digital offer, and we've got a family information service, but bringing together all of the directories and support materials and signposting for everything to do with children and young people. So that's a digital program, which is we're looking towards middle of 2027, about now actually, by the time it's fully up and running. And then on top of that, there's a number of other things that are on the go in terms of support, and like I say, for youth, and the pieces in the white paper around schools reform, and seeing them as wraparound anchor institutions within communities, which is a good place to start putting in accessible services for most children, where, because many children, you know, most children go to school, and so their families are, you know, connected to that local community school. So that's the plan in terms of managing that rurality.
Does anyone else have any questions? Councillor Pig-Hills.
Is that it? Yeah. Yeah, I mean, I welcome the ambition to always do better than whatever the targets are. I think when it comes to children, you can always do better. I just wanted to ask about initiatives sort of such as the lift, you know, the low-income family tracker, and also you mentioned the initiatives over toothbrushing and that sort of thing. And I wondered how the impact of those initiatives are being measured. You know, whether you really do see, it's okay identifying people, but you want them to then do something about it, don't you?
Well, they're quite different, obviously, in terms of the low-income families and the dental work. So we will have a number of success measures about how many children we've been able to take those services into schools. So you'll be looking at the numbers, and then we'll be looking at the forward metrics, if you like, to be looking back for the success. So I can see your question. We won't know immediately in terms of the impact, because obviously decay, for example, is a long-term issue. In terms of the lift and in terms of the auto enrolment, that project is progressing, and we'll be able to see really quickly from the census data we have the change in the number of children and families who are eligible for free school meals. And the thing with the free school meals you'll be aware of is that, and again, there's always a bit of a lag with the way that the funding works, but the funding will then flow into the schools and help them then have additional funding to be able to support those children. So we will be taking annual metric measurements from what we already have, but also adding in potentially some longer term metric measurements, because that's what we need to do as part of some of the Marmot work that we're doing, but also to see the impact over time.
Thanks. Lisa?
So I think there's something else in terms of how we're envisaging what we're doing about support in that earliest period in Best Start in Life. So some of the success of children's centres and Sure Start was about the fact that it had a universal offer, and that it was available to everybody, and that I wouldn't say that it was compulsory, but because of the way children came into school or were in nursery, etc., everybody got the toothbrushing, whether they needed it or not, and that just lifted the baseline of everybody's well-being up. So as far as we can replicate that, the work that we're going to be doing within the family centres, within early years, within schools, community projects, third sector, is to try and mimic as far as we possibly can the opportunities for universal, and then for things like toothbrushing or parenting, or for it to be offered at sort of like making every contact count, so that you getting something from it, so that that gives us a bit of a better understanding about uplift across the population, in terms of if everybody's having toothbrushing and access to that, then you will capture people who otherwise wouldn't have done. So it is quite difficult to measure, but what we know about the longitudinal studies around children's centres and Sure Start and so on is that it did make a difference. And if you measure it by outcomes at GCSE or whatever at 15, or mental well-being, health and well-being, or social connection, you can see in that period of time that longitudinal study did uplift the population of those children at that time, and that's what we're trying to replicate. So it's quite difficult, but we're going to try and get it out, make it as universal and open access as we possibly can.
Thanks. Are there any? Does anyone else on the committee have any, on the board? Sorry, have any questions that comes on it? Okay, so I want to very much welcome this report. I'm old enough to have been on the executive of this council when we were introducing Sure Start, and that was built on significant, clear research into the importance of investing in children when they are very young, and that's the best time to invest and makes the most difference. And it's a source of immense frustration to me that all the research came out that you've just mentioned a few years after the Sure Start programme, just after so many of them closed, to demonstrate how good value it had in fact been and the long-term positive impact it had. So I think as much as we can do as a county council and with all our partners to progress this approach, the better. And I think a lot of that, because we don't have the level of funding that was available then, but we do have some additional funding coming in from government, which is welcome. We need to make the most of that and tie it in with all the other resources we already have, very much in line with some of the comments that have already been made. And I think the point about a rural county is very well made. That means we shouldn't just be thinking, and I know the team are not just thinking in terms of this being delivered out of 5 physical hubs around the county. We've got to use every opportunity we have to deliver it into as many communities as possible. As some of you know, I represent one of the poorest parts of the county in Abingdon Caldecott ward in the south of Abingdon, and I know how many families have benefited did benefit over the years from what was then the Abingdon Sure Start Centre in my community, and is now run by a charity, Abingdon Carousel, who do a fantastic job, but can't possibly have the resources that they had as a Sure Start Centre. And we need to be looking at how we can deliver the things we need to deliver collectively through as many different places around the county as we can. And it's great to see in the report that we're looking at not just the voluntary and community sector, we're looking at leisure centres, we're looking at libraries. Wherever we have a presence, we should be looking at how we can use that to improve the prospects for young children throughout the county, and particularly for young children who are growing up in areas of deprivation and in households of deprivation. So I'm really positive about this. I think it's great that we've got this focus, and it needs to have a focus on it, because what we have seen for quite a long period of time now is that we haven't really dented that inequality nearly as much as we need to. So we need to be absolutely focused on doing what we can to achieve that. So I'd particularly like to thank everyone that's been involved in putting this report together and these policies together, and I hope that we'll all work collectively to do our best to work together to deliver them. So on that, the recommendations are that we note the progress of the delivery of priorities 1 and 2 under the thematic domain of Start Well within the health and wellbeing strategy, along with the key challenges outlined. Note the Best Start in Life plan, which is part of this report. Delegate responsibility for regular monitoring of progress on outcomes relevant to the Best Start in Life plan to the Children's Trust Board. Note that those outcomes will include the inequality of good level of development outcomes for children eligible for free school meals, and note that the Children's Trust Board will report to the Health and Wellbeing Board on this matter as part of these annual Start Well updates as required for escalation. So is everybody on the board happy with those recommendations? Okay, thank you very much. We're now going to move on to item 9, and I'll just say I'm planning to take a 15-minute break after item 9, just because we are making good time, give people a comfort break, and to make sure that the timings for the rest of the meeting work out. So item 9 is the Oxfordshire Better Care Fund Plan 2026 to 27, and I am expecting Karen and Isabel to introduce this item.
Thank you, Chair. So really pleased to bring today before the board the Better Care Fund for this coming year. I think firstly I just want to extend my thanks to Izzy, who has absolutely been instrumental in drawing this all together across the system. And when I say the system, this is a genuinely co-produced plan across the Oxfordshire health and care system. So I know it's taken quite a lot of doing, but I think we've got to a good place. So as we know from the Health and Wellbeing Board's perspective, bringing system partners together to look and set shared priorities and ensure that we're delivering more joined up care is absolutely integral as part of the Better Care Fund. And the Better Care Fund, as I said, is one of these key mechanisms which integration is put into practice. And I think we've described the Oxfordshire way, whether some of the neighbourhood work, this is absolutely all key within that. And it reflects a jointly owned plan across the County Council and the Integrated Care Board, which aligns our investment and to improve outcomes for the individuals that we serve. So, and I think one of the real drives for the Better Care Fund this year is to shift care from acute into communities, and we're working very closely with Michelle and the neighbourhood work around some of this. So today's paper sets out the Better Care Fund plan for 26-27, and today we're seeking the board's approval, including assurance that it meets the national requirements, because obviously this is something that we do have to submit whilst delivering against our shared ambition as an Oxfordshire system, which is to support people to live independently, stay well for longer, and experience more seamless care across the system. So is there anything, Izzy, that you want to add to that?
Thank you, Karen. Hi, everyone. My name is Izzy Rockingham. I'm Head of Joint Commissioning for AgeWell, and I've led the Better Care Fund planning process this year. So thank you, Karen. I had prepared a couple of slides which just apologies, everyone. I've prepared a couple of slides that prepare your ears that just outline some of the key points from the papers shared. So there's an overview Health and Wellbeing Board paper. There's also the narrative plan and the numerical template that we need to submit to NHS England. I had just planned to give an overview of what's in the plan for this year and some of the key changes and priorities, the funding and finances and what we've been working with, and also the system trajectories and metrics ahead of 26-27. Can you hear me? Should I switch?
Sorry, Isabel. Can I suggest that perhaps you move to the front microphone over here, please? Thank you. Apologies for that.
Is that better?
Yes.
Lovely. Okay. So in terms of key highlights for the Better Care Fund this year, 26-27 is being seen as a transition year ahead of significant wider reform in 27-28. So there haven't been significant structural changes to the funding this year, and our focus for planning has been to stabilise our performance, strengthen, as Karen said already, neighbourhood alignment, because there's an ambition that this funding will be used to support that in future, and also prepare for that shift from acute to community-based prevention and support, as Karen said. So the BCF priorities remain the same. They are aligned with the Oxfordshire Health and Wellbeing strategy in terms of supporting independence, and also our approach in the Oxfordshire way. So I wanted to pull out 4 key areas. The first is admission avoidance, so preventing people from being admitted to hospital. And the focus of the plan is to build on our strong performance on this over 25-26. So we achieved a 3% reduction in non-elective admissions for people over 65 last year, against a target of 0 growth. So that's equated to about just shy of 800 fewer admissions over the year, which is really positive and a huge success for the Oxfordshire system. And there are several services that have contributed to that. One of those is the single point of access and 999 and 111 stack provision provided in Oxford Health, which is all around supporting clinical decision support and ensuring that we can support people in the community where possible and redirect them to the correct place rather than admitting them to hospital. So we have continued investment into those services and increased investment as well this year, so that we can further our performance against non-elective admissions. For discharge, hospital discharge and supporting system flow, as we all know, we perform really well in Oxfordshire for discharge, and we've had a significant increase in discharge capacity and activity over the last year. Our focus for this year is to hone in on that further. Although we've seen an increase in activity, we've seen an increase also in the length of time delayed for discharges across all of our pathways, which is owing to the complexity of the people that we're seeing, and also staffing and recruitment challenges. And we have done some internal audits of how to improve this, and actually there are some opportunities there for us to improve internal processes, which has informed our planning for Better Care Fund. So we've included additional investment in staffing capacity and our capacity for intermediate care. And we've worked with our care market to support that capacity post-discharge as well, to ensure that there's no delays in people leaving hospital. We've also added additional investment into digital support for discharge. So we plan to invest in digital technology which works across our system, so that we can better track and plan for discharges and avoid administrative delays. And then finally, around independence, prevention and neighbourhood development. As we've said, we want to develop our approach to neighbourhoods, improve our outcomes for people in the community who've undergone reablement, and target prevention for particularly vulnerable cohorts. So that includes people experiencing frailty and those experiencing health inequalities. The Better Care Fund has long invested in those different cohorts of people. So we've continued investment and support for unpaid carers. We have schemes and projects delivered in partnership with the voluntary sector regarding prevention of falls, and also services delivered in partnership with public health to support vulnerable people and alcohol dependency and people experiencing homelessness. So that will all continue for this year. And we have added additional investment as well into our developing integrated neighbourhood teams models. So we have integrated neighbourhood teams in different areas in Oxfordshire, targeting specific cohorts, including frailty. And we've also allocated almost £500,000 worth of funding to develop our neighbourhood health and care approach, which I'm sure Michelle and Chris will pick up on the agenda later on. And then finally, just on that system ownership and governance piece, and so as Karen said, this really is a system-owned plan and system effort. We have several jointly funded system roles as part of the Better Care Fund, which are continuing, and we've added that neighbourhood development provision into the plan for this year. Also, as part of development of the plan, we have aligned funding streams. So we don't want the Better Care Fund to be organisational pound, it's very much based in the Oxfordshire pound and how we achieve best value throughout our system. So we don't plan in a vacuum. We plan in the context of other funding streams and how they interface. And we've also developed system trajectories, both against the BCF metrics as nationally determined, but also localised metrics that are specifically tailored to our system. So that's a very whistle-stop tour of what the plan is funding. This gives you an overview of the investment for this year. The headline is that Oxfordshire's complied with the investment and expenditure requirements of the Better Care Fund. We have received a £2 million uplift based on last year's 25-26 funding, meaning that Oxfordshire's received a total of 82.6 million Better Care funding for this year, but there have been no uplifts to the local authority Better Care grant or district disabled facilities grant funding, which is pass-through funding that we share with the districts, which supports people at home through minor adaptations and equipment. As I said, we are expecting significant reform to this funding over in the next year, but that is the position for now. And then just quickly on the BCF metrics. So as part of our plan, we have to put forward our targets and what the plan is going to achieve. And the way we do this in Oxfordshire is we take the nationally determined BCF metrics, which are down the left-hand side of this column here, and we set our targets to NHS England, but we also set localised targets based on our own need. So to give a very quick overview of performance last year and how that's informed our targets for next year. As I said, we've had really positive performance for non-elective admissions, and we've achieved a reduction even though we set a zero growth target last year. And particularly, I wanted to pull out the reduction in admissions for people experiencing frailty, where we've seen 2.5% fewer reductions last year. And that is partly owing also to the significant reduction we've seen in unnecessary conveyances to the emergency department as well, which is testament to our working as a system. Our plan for next year is to hold that overall zero growth for non-elective admissions, but further reduce the reduction in frailty admissions and emergency department conveyances as well. And that's in line with national targets to reduce frailty admissions as well. For discharge delays, we as I said, we want to continue with our strong performance against flow, and we're responding to high numbers of discharges, but we want to further reduce our delays to 5 days through process improvements and additional investment in capacity. Care home admissions is the penultimate metric. We didn't achieve our downward trajectory target for 25-26, but our performance against this metric has remained very stable over the last decade, and Oxfordshire's got one of the lowest care home admission rates in the country. So that's positive, and we want to maintain that performance over the next year. And then finally, and this metric is new for this year around outcomes to reablement and people remaining in the community. So it's very aligned with that supporting community prevention. There's no formal need for us to set a target against this year, but we have done some initial baselining and we've achieved 72% against this target, meaning that anyone on our reablement pathway, 72% of them have remained at home rather than being admitted to a hospital or a care home. But to Councillor Hannah's point earlier, we are doing some further analysis of that 28% who have not remained at home, and the end of life cohort and supporting those people is a key element of that. Did you want to come in on that, Karen?
Yeah, so thank you. So I think one of the, this being a new metric, we've had quite a number of conversations with DHSC regarding this, because essentially one of the things we're really proud of in Oxfordshire is being able to not have a barrier to discharge. So we take quite a lot of people through what we would view as the reablement pathway. Potentially this could disadvantage us in terms of this measure. So they're ongoing conversations that we're having, because essentially it's anybody who might have a different medical episode if they go back into hospital, and bearing in mind some of the frailty that we deal with, that could be a possibility. So I think there is something around which we're having conversations about how we look at the client level data and what does that look like, but I'm really clear that the model that we've got at the moment around home first discharge to assess is something that has significantly benefited us as an Oxfordshire system, but I don't want to be disadvantaged in terms of that success by the way that the data is recorded, so that they are ongoing conversations that we're having.
Thank you, Karen. And then finally, just on next steps, so the deadline to submit the BCF plan is the 19th of May, so next week. On the right-hand side, you can see all of the different meetings and forums that have already endorsed the plan. And this is our last stop, essentially, to get that final sign-off. In terms of next steps following submission, we have plans in place for ongoing monitoring for newly funded schemes, and we're developing specific service specifications, so we have something against which to monitor. And we will monitor our performance against our system trajectories and metrics in urgent and emergency care and better care forums, which are already established. In terms of finances, a key part of the BCF, as I said, we never plan in an echo chamber. And one of the key, I guess, the ethos of BCF is planning in a transparent way. So we've developed a system finance schedule which clearly maps out exactly who's received what funding, and given the ambition to further reform the Better Care Fund next year, it's really important that we fully understand each of those funding lines. So we have developed that schedule this year, and we've shared it with system partners already, and that will inform 27-28 planning, which is, as you can see, I've said should start immediately after we submit this plan, so that we are in good stead for next year. Thank you.
Can I just double check? When I see a screen with stuff highlighted in bright red, that's usually a bad sign. But I'm right in thinking that we have been through all those decisions, yes, and it has been signed off by all those, yes, groups. Yeah, thank you.
Yes, we have.
Is that it?
Yes.
Right, thank you. Sorry, I thought worried I was interrupting you at a crucial point. Okay, thank you. And that was, I found very, very informative and very, very useful. Can I ask for any questions or comments members of the board would like to make? I'm particularly interested in hearing from health partners on this one. You don't have to, but yeah, if you've got something useful to say, Chris.
Yeah, no problem. So I think, as it's been alluded to, some of the metrics and parameters associated with the Better Care Fund are kind of top down and put upon us. But I do think the way in which in Oxfordshire we respond to that and develop or refresh the Better Care Fund is exemplary. And I think that's massively in part through Izzy and Ian's leadership and supported by Karen and others as well. Alongside partners who contribute to the development of plan and look at schemes. Although this year has largely been a refresh, I don't think a massive amount of significant change. It still takes a huge amount of work, and it feels like each year we go through that cycle in a really meaningful and I think transparent way. So I do think it is exemplary.
Thanks, Karen.
Yeah, I think just picking up Izzy's point when she did the introduction is that we were expecting a really big refresh this year. It was coming, it's coming, it didn't come. So we've obviously had to work within the current guidelines. I think it would be worth saying, as a system, I think financially across all organisations there is considerable strain on everybody at the moment. So as part of our budget planning and our consideration as we go through this financial year will be to say what is making the biggest impact, and actually some things we may have to stop doing. And I think that is something as a system that we are aware that we've got to do and we will continue to do. But I think probably when we get the outline of what the refresh looks like, and I think there is an expectation that a lot of the finances will shift to sort of the neighbourhood model. We have got, as the Better Care Fund, the way it is set up, there are things that are baseline funded, so we are going to have some probably collective conversations. So whilst I'm signalling this is a really good plan for this year, it really does encompass all the joint working. It's notwithstanding, I think we're all going to have some check and challenge over this year about what we can and continue to fund.
Yes, thank you. And that, of course, is in the context of where we have quite significant savings to find across the county council as a whole as well, which doesn't make life easy. Any other questions or comments? Yeah, Rob.
Thanks, Jeff. Thanks. It was really interesting to hear, and it's so challenging to sort of try and make sure we're making cuts where cuts is the wrong word, making the best use of the money we've got by getting people through the system. Something just occurred to me. I'm from Cherwell, so I guess like a lot of us here representing rural wards. I was sort of following what you were saying about the sort of reduction, 3% reduction in non-elective admission, and I gathered from that is due to things like 111 and NHS Online, all that kind of thing. So that's really interesting. Now, your point about the care home admissions going up. My first thought was, well, what levers do we have to pull to bring that down? But then you were talking about reablement, and I guess that's it, and that's people going into sort of homes and helping people in that sense. Is that right? I have a follow-up to that. If that is right, my follow-up is just thinking about the rural wards point of view. I imagine if that is the case, and we're having to send resources out into the countryside, get to see people's houses, all this kind of thing, that puts extra pressure on the system. I'm just wondering, is that the case? And if so, what are we doing to sort of cope with that extra sort of requirement for rural wards?
So I think in relation to care home admissions, I think it'd be fair to say that we estimate that across Oxfordshire, probably about 54% of our population would be considered self-funding. Some people choose to make placements for their loved ones in a care home, which is quite often probably too early. So we're doing quite a lot of work at the moment with Age UK Oxfordshire to look at, some of that early intervention messaging, what support is out there. And I think it would be fair to say that when, it gets very complicated, so I won't go into the detail, but when people meet their financial threshold, we do quite often go out and do assessments, and it's not unusual for us to move people out of care homes back into the community. So there is something around the care home admissions at any one point. When we looked at it probably last year, there is probably 25% of our referrals in terms of home admissions are people we've not known about who have then placed, and then they come to us because their finances have depleted. So we're trying to do that from a parallel perspective at the moment. And Izzy might want to add to that, but I think the other thing around rural areas, one of the things that we've done, particularly with our locality teams and through our commissioning framework, is that we've got patched areas for carers, so they work in particular areas. So again, whilst that's been that has been hugely successful, and quantifying that, so before we did this new way of doing our home care delivery, we've probably gone up 25% in the amount of home care we're delivering at home, which and to put that into context, we on average provide about 34,000 hours worth of home care a week.
I think you've covered it in terms of the care home admissions. So the metric is new care home admissions, but Karen's right. We get people that are recorded as new, but they're already in a care home. It's just they've hit the threshold. But there is more we can do to support self-funders. So in terms of other options available. So that's definitely something that we're working on as part of the plan.
Thank you, Michelle.
Yeah, no, it's just speaking from a medical perspective, really. I think as we get, I think everyone just looking at the data, we've got an increasing and aging population. And really, as part of the neighbourhood work, we have always, I think, historically really focused on that top 3% that create about 45% of the problem. But actually, what we really need to do is be brave and shift our focus to rising need and people who are well now. So people understand how to keep themselves well, understand what their blood pressure is, cholesterol, keep active. We're seeing lots of that with the new obesity drugs that are coming in and becoming increasingly successful for people that have had lifelong challenges with obesity. So, there really needs to be a shift. I think for a long time we've always focused on the very frail, but really from an economic perspective, the greatest value is to go to the greatest number, and the greatest number is not the frail people. That's 3%. It's people, if we think about the segmentation, people in the green segment who are currently well, and people in the amber segment who are starting to develop chronic disease. We need to look at how we manage that and keep them well so they don't become frail, because I think we need to understand that aging is inevitable, but frailty isn't. And so just it's a shifting mindset that we all need to think about as we move towards sort of a new neighbourhood model of care.
Thank you. And at my age, that's very encouraging advice. Yeah.
Yeah, that's right, Michelle. I think that's really true about embedding this support in neighbourhoods and voluntary sector groups. Just to say, we've been doing the Marmot outreach across 14 rural areas. We'll talk about that later, but this is one of the issues that has been coming up, particularly around people getting to an older age where they can't cope with their housing. And so it ties into so many different factors across that informs those decisions about why people are giving up and going into care homes prematurely when they could be supported at home.
Thanks, Kate.
Yes, just to follow up on that further to what you've said, Michelle and Veronica, you're talking about earlier treatment, so to prevent people becoming frail. And in fact, I would say even earlier than that, a focus on the wider determinants. So things like the housing and whether the housing is suitable or whether they have financial security and what we can do with that. Embedding that prevention approach into our neighbourhood health offer will really help with this whole agenda and bringing down the numbers needed to be supported by adult social care.
Thank you. Any other questions or comments? Councillor Pickles.
I think that was interesting what you just said, that ageing is inevitable, but frailty isn't. And I know this is a slightly personal anecdote, but I have a friend who's about the same age as me, who a month ago would be walking quite happily several miles. He had one fall. A day later, he had 2 further falls. He's just moved to ground floor flat, so he thought, oh, that'll be fine. He was just about to get moving again, went outside because he'd badly hurt his knee, and he's fallen again. And he's emailed me today to say he's wondering now whether he should go into the, what do you call them, where you've got a warden and a lounge. Which sort of 6 months ago, 3 months ago, 2 months ago, he didn't need. And suddenly his life has just changed just like that. You know, and I think I found that quite scary, really, because I say he's the same age as me.
Thanks. Yeah, and I think it's important to remember in all these, I'm sitting here thinking about my dad, and who's probably going to need to go into care at some point in the near future. It's important to remember that these are all individual people, and it's hugely important that we hit the targets that are in this kind of plan, because that overall that means we're doing the right thing and we're helping more people continue to live independent lives for as long as possible. But we also need to make sure it isn't just a numerical target. It's about the care that we show to each individual person that's involved in that process. Thank you. Any other questions or comments on this? No. Okay. So the recommendations then are to note and approve the direction of travel set out in this report for the Oxfordshire Better Care Fund plan for 2026 to 2027, and the decision-making process set out in paragraph 14 to approve the Oxfordshire Better Care Fund plan for 2026-27, and the decision on the assurance statement set out at paragraph 19 of the main report for this item for submission by the 19th of May 2026. Is everyone on the board supportive of those recommendations? Yeah, thank you very much. That's agreed. I'm going to suggest that we take a 12-minute break and reconvene at 2:20. And if we're ready to do item 6, we'll do item 6, and if not, we'll carry on through the agenda until we get to that point. Thank you. Development Officer and Well Together Programme evaluation. And I think Kate Holborn is going to introduce, and then Professor Charters and the other Kate are going to contribute.
Great, thank you. So I'm really pleased to introduce this evaluation item. Both the Community Health Development Officer and the Well Together programme are programmes which form a key part of our understanding of a system-wide approach to tackling health inequalities, obviously adopting the Marmot approach as well. So we're really focusing on the social determinants and understanding those inequalities at community level. The Community Health Development Officer programme has come out of the Community Insight Profile work that we did, where we placed officers in those communities to really help them to work with the assets that they'd identified and address some of the needs that had been identified at a local community level. The Well Together programme has provided targeted investment into community-led activity, so really enabling grassroots organisation to deliver projects, delivering on the needs that have been identified locally. So this evaluation has been carried out by Professor Erica Charters, and it's been really important to have an independent academic evaluation so we can get an objective perspective on the impact that these programmes have had for us. So I'm going to pass over to Professor Charters to give us a review of this.
Great, thank you very much. So as mentioned, my name's Erica. I'm Professor of the History of Medicine at the University of Oxford, and this role that I had running the project came out of my broader role as Head of Medical Humanities at the University of Oxford. So as mentioned, it's 24 months that we did the evaluation. We just have finished the full policy report, so all 60 pages will be available to you very soon, I promise. I think the executive summary is already available. We're also working on producing 6 community health films, which will be released in June, and we'll also be finishing off some academic publications. Can I get the next slide, please? So as you'll know, because these programs started in 2024, we knew that there wasn't going to be a change in kind of population health data at that level. And so we focused on thinking about partly the implementation of the program, but also really looking to see how did these programs actually achieve their objectives, or did they achieve their objectives? And this is really to take a community-based approach to encouraging and supporting community health and well-being. Next slide. I'll jump right to the findings so you don't have to wait to the end. So we found through qualitative and through quantitative evidence that indeed both programs were very effective in terms of fulfilling their objectives. They were very good at collaborating and coordinating with local anchor organizations, also with local grassroots organizations. They funded over 150 community organizations, and through that meant that they supported more than 200 community health and well-being activities throughout their lifetime. One thing that we really found in our research is that the individual officers, so this is the community health development officers, and then for the Well Together programs, they're called community capacity builders. These individuals are real strengths of the program. We found they were very good at networking and communicating with local communities, and this meant that they developed these very trusted relationships. And overall, what we found is when we think about community health, we should think about it as something that is actually part of a broader ecosystem of health and medical care. So very often we found community health is a kind of pathway. It's where residents kind of start to access formal medical care, say through NHS screening. It's also where people come when they're leaving formal medical care and where they go for routine and for contacts. So it makes most sense to see these things within this kind of broader infrastructure and not simply to look at community health on their own. Next slide, please. So how did we do this? It wasn't just me alone. I had a great team working with me at the University of Oxford. So along with historians, we had anthropologists, economists, we had public health specialists. We also had people from population health. It was interdisciplinary in terms of our research. And as I mentioned, we kind of divided our evaluation into 3 parts. We wanted to look, first of all, thinking to really understand the context of the 10 priority wards, to understand what the issues were there, what assets are there as well. We then looked to see how it was actually implemented and looking at the practice of funding through these 2 programs. And then finally, we wanted to see how did residents, the kind of target communities, how do they actually, and whether they actually did engage with these programs overall. We used official statistical data. We also did detailed household surveys. So we visited 1,600 households in the targeted neighborhoods. We also ran focus groups, semi-structured interviews and workshops. And we also did a lot of field work where we spent time in the community health activities to see how these functioned and how people made use of them. Next slide, please. So for the first strand, when we looked at implementation, what you might do is for these two programs, they were given an amount of money that they could use to allocate funding, especially drawing on the Marmot principles and also drawing on the community insight profiles. And what we found is this grant funding really enabled these officers to connect with local community groups. So as I mentioned, there were over 200 health and well-being activities that were funded through this round of grant processes. The other part that I think we highlighted that was very important is this wasn't just people handing in applications. It was actually about the process of how this should work. So especially for Well Together, they not only gave guidance and support to people who were applying. When they saw applications coming in, they'd actually look to see whether there were overlaps and they'd have groups coordinate with each other. And so the point was to not have people competing over small pots of funding, but rather to think about how you can build up networks even at that stage. Next slide, please. We spent some time thinking about how to evaluate these programs in practice. So one thing we did is we actually spent a lot of time working with the community health development officers and the community capacity builders. You can see this is a kind of table where we actually tracked where they spent their time and how they spent their time. A really key point we found is for these officers to have regular presence in their community, spending a lot of time seeing what the issues are down on the ground. We found these people have just really excellent communication skills, almost all female, very engaged. And we noted that, of course, this is what allowed local community organizations to work with them and to trust them, not necessarily see them as impersonal, but as a people that they were very familiar with. Next slide, please. Then in order to think about these in practice, we also spent a lot of time actually working with the community health activities as they were offered. So as I mentioned, there were over 200 of these, and we actually spent time doing field work with 50 of them to get a sense of how they work. When we think about community health and well-being, this is obviously very broad and varied, and I have to say it's a massive umbrella. And I think there's a lot of things that we know fall under community health, so things such as nutrition, Oxford Mutual Aid, or things such as sports and exercise. But this also includes things such as the Repair Cafe or Restore, which I think people don't always immediately connect to health. Something which we found very interesting is when you talk to participants, they were very articulate about what it means to do, say, something such as an occupational activity and how this is important not only to their mental health, but also to how they connect with their local community. We also found that there's a lot of overlap between what you might call the recipients or the participants and the people who organize. So an organization such as Restore, you might know that you spend many years as a participant, and then in some ways what you do is you graduate to becoming an organizer. And we found that the people who organize the activities, they're often volunteers, and they talk about how that role is actually very important to their own health. So there's a lot of fluidity when we're talking about community health and well-being. One of the important points we make is that what these activities do is they make health and well-being a regular part of your life. It's not a specialized intervention. It's just something that you do on a daily or even on a weekly basis. And the other point is that we see these and we define these very much as what we call foundational public health. So again, this is the way where people come into a health system very often, right? It's the way that they think about how to access their GP or access other local services. And we also see for various programs, Restore is a good example where it's people who are coming out of this the system and trying to understand how to build up regular routines and contacts. Next slide, please. This is my last one, just thinking about practice. So in order to think about engagement with these activities, one thing we did is, as I mentioned, we did a survey of 1,600 households. And for this, we drew on the 2021 census and looking at basically what were the most deprived areas in the 10 priority wards and visiting those households in order to talk to them about what they made use of in their community and their ideas of health. And we found excellent engagement. So for this, 2/3 of households that we spoke to either had heard of or wanted to use or had used the community health development officer or Well Together funded programs. And 1/3, over 1/3, had actually directly participated in those programs, which was a great finding that we really weren't certain what we were going to find. In terms of who's using these programs, I think some of this is not surprising. So There's a kind of key age group, those between 26 and 49, who are most engaged. Very often it's families who have children. Women engage much more so than men. An interesting finding we found is actually there's much higher participation among ethnic minority groups. So we did want to flag up that obviously the elderly white male is a group that tends to be kind of still difficult to reach. We also looked at reporting from those who organize the activities. So 93 of the activities actually gave reporting on how many people had participated. From those, we had a total number of 20,000. And so since there were over 200 that were funded, we can very easily say that at least 40,000 residents engaged directly with these programs. Another thing I want to add is when we were talking to people in households and we asked, when's the last time that you did a local community activity or a health activity, they would say, no, we don't do that kind of thing. And so instead what we had is we actually had the titles of all the activities that were funded by the 2 programs in their ward, and we read those out, and people then said, oh yes, I do those things. So it's quite clear to us that we found residents don't use the language that we do. They don't talk about well-being. They don't talk about community health. I've also put that funny little thing with terrible writing on there, just in case you can indulge me for 30 seconds since I'm a historian. So this is the oldest census that we have in England. It's the Norwich census from 1570. And you might be wondering, why do we have a census from such an early date from Norwich? So back in 1570, Norwich was a kind of central international hub for trade. They had a lot of merchants coming in from overseas, a lot of wealthy people. So in other words, there was a high level of immigration. There were a lot of wealthy people who were very worried about what we might call rising tax rates. And so what they did is they decided to count how many people were poor in their neighborhood. And so they went door to door collecting data. And so this means that it's actually one of the earliest records we have of a record of people's health. Because within this, if you can see, there's these funny little square parts, and it looks like there's very bad handwriting that says Hable. And that's actually their way of writing able, which means whether or not someone was able to work, that is whether or not they're healthy. And so I found this very interesting that even 500 years later, the way that we kind of know about people's health is whether or not they're dependent on government services. Next slide, please. So just to kind of end with some recommendations and overall points, obviously we know that health is scientific and biological, but we really want to stress how much of it is also social and cultural. When we were going door to door, we asked people, when were you last concerned about your health, or what makes you concerned about your health? The majority of people talked about not their own health, but the health of their parents, their children, and their spouses. So it's a really important point to stress that people understand health through social relationships, and they think about their health through households rather than through their own individual health. This was the same thing when we asked people, what do they like about where they live? People will talk about green spaces and local infrastructure, but the majority of people talk about their neighbors and whether or not they like them. So we just want to emphasize this kind of social and cultural context when we're thinking about community health. The other thing we found, of course, is that residents have very long-term memories. When we talk about what people have done, the average number, I think the average years that people had lived in their neighborhood was at least 12. We had many people who'd lived there for their entire life. They're very aware of what changes have happened. I find as a researcher, probably as policymakers, we're told to always innovate, but we actually found that residents really want something that's sustained so that they can trust it and engage with it. And I just like to emphasize that, of course, when we're thinking about health, we want to put it into these social and cultural practices and to really think about how community health doesn't just stand on its own, but it should be really seen as part of this broader public health infrastructure. Thank you very much.
Thank you very much. That was really interesting. I was particularly struck by your point about how people talk about health in terms of their own family, because in the course of this meeting already, I've thought about my dad and about my kids' experience, and that's really, really interesting, actually. I'm just going to start by saying that my community, again, that I talked about earlier in Abingdon South, is one of the areas that's benefited from this scheme. We've seen additional funding going to the Abingdon Carousel Family Centre. We've seen support for the Abingdon Bridge, which is a mental health, excellent mental health charity in Abingdon that supports young people. And now based just around the corner from where I live, the Community Shed, which is a facility aimed at getting men together, primarily men together, I don't think it's exclusively men, primarily men together over developing woodworking skills in conjunction with with Oxford Wood Recycling, which is based in South Abingdon. So in my community, we've definitely seen a lot of benefits. That's just some of the projects, and a very high level of engagement with a very significant number of local residents. And it's been really impressive to see that work being done. Does anyone else have any questions or comments that they'd like to contribute? Georgina.
Hello there. I know it's always difficult to see that tiny little hand on the massive screen. Thank you for that report. Excellent engagement. I really enjoyed listening to that. As Neil's commented, really interesting to see focus on repair cafes and social relationships for mental health and a more comprehensive approach. Really enjoyed that. I just wanted to ask a little question, really. I've probably being a bit nerdy about the surveys. You mentioned that you'd issue, I just wanted to clarify, did you issue around 1,600 surveys, or did you actually get around 1,600 responses on the surveys? I'm always interested in community engagement, and I'm just interested to know what the level of response was.
Yeah, great question. I wish we had a full 1,600 surveys. So what we did is we visited 1,600 households, and from that we were able to get a detailed interviewed feedback from 225 households in total, and that was spread across the 10 wards. I will say that these were in-person, face-to-face interviews, so very often we told people we'd only need to talk to them for a few minutes. People often talk to us for much longer than that. So some of the most detailed qualitative and quantitative data I think we have on these communities. And I will also add, it was very important for us that we go to people in their households. I know that most people do focus groups or send out surveys. One of the things we really wanted to make sure with our research is that we were talking to the groups who likely don't engage. We had people who talk about how they don't leave their house very often. So I think it's just something to think through the methodology. But yeah, and if we had more time, we'd love to talk to more people.
That's really helpful, thank you. And I think the personal engagement is, as you said, probably provides a much more qualitative response. But it's a shame you couldn't get the full 1,600, but I fully understand why. It's always tough, isn't it? But thank you very much. That's excellent.
Thank you. I think anyone that's just been through a round of local elections knows how much work is involved in having quality conversations with even 200 people. So that's really, really good work. And thank you for your question, Georgina. Nothing too nerdy for this board. Veronica. So, going to go for Veronica next.
Thank you. I mean, it's just to reflect, I was working with some of these Well Together groups yesterday, and I think through this time, there's been a growing trust and, a reversal of the sort of cynicism and feeling that nobody does anything through that method of working. And I think it's so important, that trust building that's taken place. And I think the other thing, the question about, you pointed out that more people from global majority, ethnic minority backgrounds are there, but I think that also reflects they've got incredibly strong networks that you were nurturing and building on through those programs as well in the first place. So it's a two-way thing, isn't it?
Thank you. Councillor Gore.
Thank you. Thank you. So I was trying to work out from the recommendation, which is entirely inoffensive and supportable, but I was trying to work out what the and what is, if I'm explaining to residents on the doorstep what we've been up to and what it means to their lives, what it is that I could then say from this recommendation. I wasn't totally clear. I've gone deeper into the report, and I think that it becomes really much more interesting because we've got some real tangible, hard stuff that is actually happening, which is we've got, officers employed in order to affect this area that's going to be really important to lots of people. We've got some very specific areas of the 10 most deprived wards across Oxfordshire. So again, I get really into this. So what I'm trying to think now is how effective do we think we can be in this space, and by effective, if the 10 deprived wards are still the same deprived wards in a few years' time. Bluntly and harshly, I wouldn't think that we've been that effective. I would think that we've just maintained status quo, but maybe helped a few people along the way. Like, can we be as effective as actually looking at 10 different deprived wards in a few years' time?
So it's a great question. I feel like this is also, I know that there's been different designations about which wards, and I know that more wards have also been brought into the program. Kate, I don't know if you want to elaborate on that. And one thing I think that we were very aware of with this program is in some ways this is actually quite small scale. And so of course, if we're going to say that having one community health development officer in a ward is going to change the whole population level health data. And I can't imagine that we can really just evaluate this program on its own. So I agree with you that it's very hard to take this one evaluation or this one program and kind of talk about substantial changes. I think it's one of the issues we saw from the outset in terms of the evaluation, to think about how do we think about whether we're changing people's lives, and can we do this just through quantitative data alone?
Yeah, thank you. A really interesting question as to why we're doing this. So first of all, to talk about the deprivation, obviously that is measured through the indices of multiple deprivation, and the comparison between 2019 and 2025 was favourable. We can, of course, not put causation between particular programmes and that change, but that change has happened. The point of us doing this evaluation is we put programs like this in, but we need to really understand the impact it's had, so we know which learnings to then take to future programs and future wards that we work with. So this evaluation has been really valuable in helping to understand what the residents got from it, and does that match with what we thought they were going to get from it, and how we can take that forward. And Veronica's going to tell us soon about some of the work on rural, understanding the rural inequalities, and we'll start to think about how we can share these learnings between different areas.
Yeah, I'll add to that. But firstly, I don't think you meant it this way, Sean, but it absolutely isn't our objective to replace these areas of deprivation with new areas of deprivation. That's not what we're trying to do. It is about for me, it's about identifying what things we can do that actually make a difference in terms of reducing the relative deprivation in those parts of Oxfordshire that are the most deprived on the current measures. And we have to be realistic about that, because a lot of the factors behind that historic deprivation, and in all, I think I'm right in saying, in all 10 wards that we initially identified, that they have a history of being relatively deprived that goes back decades and decades and over generations and generations. It's not something that there's a quick fix to. And a lot of the factors that affect that are down to national policy, they're down to history of those communities, and realistically, we're not going to change that. What we need to do is identify what can we do that does change, that does shift the dial. So I think for us as a county council, and for the other organisations, district city councils and the other organisations represented here, it's about looking at this as a learning exercise. What can we learn from this about what works, what doesn't, and look at how we can then put in place more of the things that work going forward, and tying that into the things we discussed earlier in the meeting around all the other things that we're doing collectively to try and improve people's health and well-being across the county. So for me, this is a really important information and evidence that can feed into the decision making we go forward with to try and shift the dial in the future.
Just very, very quickly, I agree with you. No, we're not trying to replace one deprived ward with another deprived ward. My point is I think we'll, get, which is, the 10 most deprived wards in Oxfordshire, we will always have 10 most deprived wards in Oxfordshire. And if we are really successful in supporting the most deprived wards become not the most deprived wards, then by default they'll be replaced by another, but hopefully less deprived, because of the activity that we've been doing.
I knew what you meant. Please.
I was just interested in a little bit more explanation about the recommendation around multi-year funding. I mean, that's very aspirational to be looking for multi-year funding. And I was wondering, does that encompass just the community development workers, or is that encompassing money that's going to the voluntary sector? Because the voluntary sector obviously really struggles to obtain multi-year funding. So could you just give us a little bit more explanation as to who you're pointing that multi-year funding at?
Yeah, I feel like this is the part where I get to say I'm a researcher rather than a policymaker. So obviously, I just get to report on what we found in our research. And of course, everyone we talked to talked obviously about funding squeezes. I think one thing that we found very interesting is we spend a lot of time talking to people who've organized these community health activities and what they've done over many years. Many people have been doing this for over 10, 20 years. And what they say is obviously the funding landscape has become more competitive in various ways. And one thing that they also noted is that there's a pressure to constantly come up with new things, even though the people that they serve really want what they've always had. So from our perspective, it was really just to highlight this tension that we see between, on the one hand, this notion that we should constantly be innovating, and this notion that obviously what people really want on the ground is something that they can rely on and that's dependable. And we know that whether it's in the realm of global health or whether it's in community health, that obviously what you want are projects that are sustainable and stable as well, because that's what leads to trust. Now, where that funding comes from, luckily, I don't get to say. All I can do is tell you what we found in our research.
Thank you. Any other comments, questions on that? No. Okay, so the recommendation is to support the promotion and sharing of the findings from the evaluation of the Oxfordshire County Council funded Community Health Development Officer programme. It's quite a mouthful. And the Buckinghamshire, Oxfordshire and Berkshire West Integrated Care Board funded Well Together programme, also a mouthful, with partners and colleagues across the system. Is everybody happy to support that recommendation? As Sean said, not a difficult one to support. Thank you, and thank you again for all your work. Oh, sorry, Councillor Pickles.
Should we change the recommendation from Bob, because Bob is not a thing anymore, is it? It's Thames Valley.
I'm happy for it to be changed to whatever is accurate at this moment. Can you take that on board, Omid, when you write up the minutes? Thank you. So thank you again very much for your work on this, which has been incredibly helpful, and I'm sure we will learn a lot from it. Thank you. Right, so we are on to item 10. All right.
Yep.
Yep. Oxfordshire Combating Drugs Partnership Annual Report, and I'm expecting this to be Tom and Sam. When you're ready, Tom.
Hi, everyone. Thanks very much indeed. My name's Tom Addy, and I'm now acting consultant in public health in the public health team at Oxfordshire County Council. I'm also joined by a colleague online, Sam Reid, who's public health programme manager and the lead for the substance use services at OCC. I will just share my slides. Okay, so today I'm presenting the annual report for the Combating Drugs Partnership, and also just taking the opportunity just to sort of update the board on some next steps relating to an update of the Oxfordshire Drugs and Alcohol Strategy. But before I start, I hope you don't mind me just taking the opportunity just to take a couple of minutes just to talk about language. And this is part of our efforts that we're taking as a Combating Drugs Partnership to tackle stigma in sort of all public and partnership meetings. I just wanted to draw attention to a couple of the points on this table, which is in development. First of all, just a couple of points on terms. So previously in our strategy, we tended to use terms like substance misuse services and at times sort of things like substance abuse or misuse or problem use. As a sort of partnership and public health team, we're really trying to sort of move away from those terms, which tend to sort of promote stigma and sort of a lot of blame on the individual. So you'll see throughout the presentation, I'm sort of using terms such as drug and alcohol treatment services and substance use rather than substance misuse. And hopefully sort of yourselves as sort of leaders and sort of engagement with the public can sort of take that on as well. So thank you. So in terms of the background to the Combating Drugs Partnership, for those who weren't aware, it was established in October 2022, and it's the local delivery mechanism for implementing the national 2021 national drug strategy from harm to hope, which was a sort of really landmark strategy in terms of tackling harms from drugs. So the Combating Drugs Partnership brings together a wide range of partners from across the system to reduce harms from drugs, including alcohol. And I've sort of listed a number of those partners here, many of which are represented on this board. The key priorities are around reducing drug use, reducing drug-related crime, reducing drug-related death and harm, and increasing people entering treatment and recovery. The Combating Drugs Partnership is responsible for data monitoring and intelligence to understand the sort of surveillance and trends around drug and alcohol use, overseeing the local drug and alcohol action plans, particularly around sort of grant-related activities, identifying emerging issues and threats, and that's particularly around sort of new drugs that may cause sort of particular additional harms, and having that kind of real-time surveillance and harm prevention, and providing visibility and accountability for drug and alcohol use issues, and a real sort of partnership forum for coming together on that. In terms of sort of the context for Oxfordshire, so the partnership published a drugs and alcohol health needs assessment at the end of last year. I've sort of provided the link in the slides to that, and in the report you have it sort of highlighted some of the key points. I won't go through all of those today, but just to sort of say overall, as I'm sure sort of members were aware, Oxfordshire tends to do better compared to the national average when we're talking about the harms associated with drugs and alcohol in terms of sort of lower rates of death, lower rates of sort of hospital admissions. And also does really well in terms of sort of engagement with treatment services and sort of meet sort of the way in which services are meeting that estimated need in Oxfordshire. There's also some sort of success in terms of elimination of hepatitis C and other things like that. But as with a lot of these things, and common theme across a lot of things we discuss, these are obviously averages, and the averages for Oxfordshire can often mask those sort of significant health inequalities that persist sort of across the county. And I'll do a little bit of an example of that in the next slide. There are also some particular needs that were highlighted through the needs assessment where perhaps Oxfordshire's not doing as well, or some areas of focus. So it's estimated that around 4.3% of children and young people are affected by parental drug use, and we know that can have sort of a range of different sort of negative impacts sort of throughout children's life, and then means that they may be more susceptible to drug and alcohol problems when they're older. I'll talk a bit more about it, but we sort of have some particular issues in terms of how we can engage young people in treatment services and sort of meeting that unmet need in this area. As I've touched upon, there's substantial inequalities, and that's very much sort of picked up through the Marmot work and other areas. And we've seen a little bit of a drop in things like hepatitis B vaccination amongst people who inject drugs. And as I've sort of alluded to, there's sort of constant sort of emerging threats in terms of things like synthetic opioids, and we're seeing kind of increasing health harms through things like ketamine use, particularly amongst young people. And there was a GP education event on that a couple of weeks ago. So just to sort of drill into a bit of a case study, and this is just I could have probably picked a lot of things, but this is just off the Oxfordshire County Council data hub. And I've sort of picked out hospital admissions for alcohol liver disease, just because it is one area that unfortunately the sort of metrics are going in the wrong direction in Oxfordshire, but which reflects how things are looking from a national position. But I just wanted to sort of highlight this as an example, both to sort of show that there's obviously that kind of variation. Here's just being pictured at district level, with sort of Cherwell districts sort of statistically higher than the national average, Oxford and West Oxfordshire and the county as a whole are sort of statistically similar to England, and then the districts in the south being statistically have statistically lower rates. So now on to sort of the report itself. Hopefully you've sort of had a chance to sort of read that, but I'll just pull out a couple of sort of key things. So overall, good progress has been made over the period. It's an annual report, but just because we were originally going to present at the end of last year and it's been sort of pushed to now, so it covers closer to an 18-month period, if you're sort of wondering why this is sort of 24 to 2026. Some of the key achievements, so we've had a really good increase in numbers of adults accessing drugs and alcohol treatment services. strong performance against the national continuity of care. So that's supporting people who leave prison, who may engage with substance use services within prison, continuing that as they enter into the community, which is obviously kind of a really important service to then sort of prevent reoffending and sort of stopping people kind of returning to sort of substance use. There's been really good expansion of naloxone. So for anyone who's not aware, naloxone is a really effective drug. It's, in terms of the community, it's normally used in terms of a spray, which can be given to people who are experiencing an opioid, including synthetic opioid overdose. Very simple to administer. There's been changes to regulations, which means that it can now be delivered through community pharmacies. So anyone who's a sort of either at risk themselves or sort of partner or family member can access that and have those kits at home in the event of sort of a loved one or friend experiencing overdose. There's also been really great engagement from Thames Valley Police around this, with police officers carrying sort of naloxone out in the community. There's been a strengthened response to eliminating drug threats through the local drug information system, and that's a really key aspect of reducing drug-related deaths and drug-related harms. So that means sort of that real-time surveillance, again, understanding where there might be a particularly harmful drugs or sort of contaminated batch of drugs circulating, and making sure that information goes out to the police, other services working out in the community, and also to people who use drugs themselves. Some ongoing challenges, so I sort of alluded to this, but declining numbers of children and young people accessing substance use support, and the persistent inequalities in drug and alcohol harm. And a couple of these things I'll sort of go into a little bit more detail on. I won't dwell too much on this sort of governance side, but just to say that we've got a sort of number of task and finish groups that sort of underpin the Combating Drugs Partnership, and I'll do sort of a little bit of an update from each of those, so we'll move forward from that. So the first one is the Reducing Drug-Related Deaths Task and Finish Group. As mentioned, there's been a real focus here on reducing carriage and distribution of naloxone. So the supply at local pharmacies, since its launch in 2025, there's now 29 pharmacies across the county, with 141 kits supplied, and that rollout amongst the police. From a CYP, children and young people's perspective, here the partnership's really been focused on sort of building those partnerships, so working across schools, youth offending teams, mental health services and other areas, to strengthen those referral pathways and promote the service, and really kind of trying to expand those links to make sure that sort of where children and young people are experiencing substance use issues, that they are able to access services. But that does remain an ongoing challenge. So support from the board and sort of helping that would be very welcome. The next point, and mental health task and finish group, and again they sort of really focused on strengthening those pathways, and particularly that continuity of care pathway that I referred to before, in making sure that people as they leave prison are able to access community services. There's also been a lot of efforts sort of driven nationally, but around preventing people going into prison, and those drug DRRs, drug rehabilitation. Anyways, essentially kind of instead of people going into prison, they will access sort of community treatment services instead as an alternative. So that's obviously put additional sort of pressure on services in terms of that capacity, but it's been has been really successful. And we also work in partnership with Thames Valley Police, so they sit on the Combating Drugs Partnership, and that's really about sort of making sure that those links are there between the police and health, and it's a sort of two-way link. TVP have got their own drug strategy, and I think they see the Combating Drugs Partnership as kind of a key part of sort of inputting into the work they do as well in terms of enforcement. Work is further underway to expand community and lived experience within the group. So having that involvement of people, experts with lived experience, It's been really sort of key since the group's formation, but we're actually, the group are looking to actually formalise that properly. So a sort of case has been approved to actually sort of go out and commission some formal lived experience engagement. So the sort of tender for that's going out in the summer, and happy to sort of provide a bit more details on that if it'd be helpful. So that's sort of the main report. As sort of referenced in the report as well, we're just in the process of updating the drugs and alcohol strategy. We sort of got the strategic context of the harm to hope strategy. As I mentioned, the health needs assessment came out at the end of last year. So we're now really taking recommendations of that. We ran a big sort of collaboration session with a whole range of partners last month to sort of talk about the themes from that and sort of identify the issues and solutions really. So that will sort of inform the next stage, which is bringing together the key sort of strategic priorities and the action plan. I think in terms of our approach for that, it's really making sure that it's a really action focused strategy. I think we really want it to be, particularly noting all the kind of system changes that are coming, really kind of directed at where we're going to deliver the biggest impacts in terms of reducing drug related harm, where local partners can actually, where are the levers and where can they have the biggest impact. So yeah, our criteria is thinking the scale, what are the big issues, where can we have the biggest impact locally, and making sure that we've got that focus on health inequalities. So as that sort of strategy develops over the sort of next few months, be really keen to sort of keep the board involved in that. So that's everything. I will pause then. I'm very happy to take any questions, and thank you for your time today.
Thank you very much, Tom, because you're acting up. Well, I thought you behaved perfectly. Michelle.
Okay, thanks for that, Tom. Really interesting. I'm just interested in the children and young people and the challenges around engaging them in services. What are the barriers that they're telling us for them engaging? Because sometimes we're very good, I know, in health at creating challenges for people accessing a service. I've heard multiple times from young girls about challenges accessing the pill or emergency contraception, which we have made real progress on now. People can access that at the community pharmacy without having to get a GP appointment or parental support. So it's really, what are the barriers that we're putting up, preventing people accessing the service? And also, are we engaging young people on their terms? Asking people to go and meet someone in person might not be the way to engage people. Are we engaging digital as an initial thing to try and support people, which is much more the way our young people, live their lives now?
Yeah, thanks, Michelle. So I think there's a number of different sort of challenges that have been identified. So I think awareness of the service has been identified as a key barrier, and in terms of sort of the raising profile of that, so the provider Cranston are sort of doing a lot of stuff around digital, social media, different campaigns and stuff to raise it, to raise the sort of profile and understand how to access it. I think there have been some sort of barriers in terms of different referral routes into it, and certain areas have been more proactive in terms of kind of, I suppose, referring sort of relevant sort of children and young people into it. I think it's a really good point in terms of in terms of that access point and exactly how services are delivered and how they're accessible. Anecdotally, you hear things about children and young people not wanting to access certain services like this. They might not, they might not want their parents to know, and we think when, again, it's a little bit anecdotal, but when children and young people are having find friends and stuff on your phone, they may not want to go into an obvious sort of substance use service. So I think they're kind of all sort of barriers to look at. But I think there's also an element of actually thinking about what's the right model, and I think as we go into thinking about the strategy and sort of working with the provider around that, we're kind of keen to think more innovatively, I think, around how that service is delivered to tackle some of the points you've raised.
Lisa.
So I can probably help you out a bit. I'm Director for Children's Services and I know what the young people are telling me. So okay, it is about the referral pathways and it is about it being a little bit too clinical. Children often don't recognise that they've got a problem with substances because they think of things like intravenous heroin use as opposed to things that grow on you in terms, you escalate or health issues. They don't like to go to clinics. They get scared when they have to provide consent and fill out forms. And the best way that we find is that if you've got some use issues, that comes amongst a whole range of other things, and you probably need to be with a trusted adult or professional who brings someone along and says, this is someone who we're going to have a little chat, as opposed to you have a problem with drugs and you're going to be treated over there or whatever. Now there's some compulsory places where that might happen, for instance in youth justice when it's part of an order, in which case it's very specific for the courts and things. Or there are a number of children who might be having drug and substance misuse issues as a result of crime and exploitation and will be very, very worried about this because they owe money or they're in a bit deep. So it is about a review of the process and going to where children, young people are, and being a little bit flexible, I think, about how we introduce that idea amongst a number of other conversations we have with them. And I know colleagues in my directorate, frontline workers are really happy to do joint visits and bring people along, especially the youth work service, for people who would rather not be seen by authority or whatever, and perhaps don't even realise that what's happening for them is a problem. So we've got to think of a little bit more of a flexible way, a more relational way, I think, of doing that, because that whole bit about treatment is immediately judging and, so those are the things that they say, and those are the things that my staff pick up. And we know it works best when you sit alongside someone and you have a bit of a conversation rather than in a mental health aspect. You don't go into therapy and you don't disclose stuff by sitting in front of each other and just have it, does that make sense? It has to be just sort of woven into the fabric of all the things around their life. And those are the things that are causing anxiety about access for young people.
Yeah, no, thank you, Lisa, and really good points. And I think as you've sort of highlighted, that link in with other things that are going on in their lives is sort of really is really critical, and kind of the point about not necessarily sort of recognizing it's an issue. If see other people do similar things, we know that. So yeah, really keen to kind of, as we do already, sort of work across with children's services around these things. So yeah, thank you for that.
Yeah, thanks. I guess there's an issue of how we link in with, on that point of trust, the organisations that are out there often in the voluntary community sector that do have that trust with the young people in their communities. And in my context, whether that's the Abingdon Bridge or the Damascus Youth Project or whatever, and how we work with them to get that sort of communication link out there. And so, yeah, Sam, I have seen your hand. I'll bring you back in a minute.
So I think it's exactly that, and being a little less more flexible about who can host and who can have, for instance, Cranston workers on site have a tendency to think that you've got to go as though you're going to the GP and then sit there and be treated. And that's not, and kids won't fill out forms. And when you ask them for their consent, their automatic view is no, I'm not signing anything. Whereas actually, if you want to sit down and talk to them over a coffee, or they're doing something else in, say, voluntary and community youth work, they're quite happy to open up. And sometimes we'll say, yeah, do you know what? I will speak to somebody about that. It's been worrying me. So it's being open to a bit more flexibility and trusting of other people in the partnership and the networks to host and to invite people in. Vast majority of children are not at that very serious end of drug use where they're in rehab or anything. That's few and far between, but there is some problematic use that causes issues.
Yeah, and as you mentioned earlier, the risk that that's the start of it, but then they get into other negative behaviours or problems with crime or whatever as a result of starting that journey. Yeah, okay, thank you. Sam, sorry, you've had your hand up. Apologies for not spotting it initially.
No, that's fine. Thank you. I just wanted to add to some of the points that have been raised about the sort of current delivery and what we're doing around youth participation. So in terms of, as was quite rightly picked up, making services attractive to children and young people is incredibly difficult to get them to increase that accessibility, to get them to walk through the door or to meet with a worker. A lot of things that are already available. So they will come and talk to you in a school or a cafe or a youth club. And at this time of year, we start to increase doing walks in the park and things like that to engage with young people. So the service absolutely does come to where they are. I think there's a lot of work that we need to do and the service still needs to do around making partners across the system aware of the service and what the service offer is. And unfortunately, it is still quite a small service and they do struggle with being able to get everywhere. But as part of the work we've been doing with them to look at that model and how we can make the service more attractive to young people, they're doing a number of things at the moment. So they've absolutely looking at that digital offer in terms of having a digital front door for services so young people can access directly and book an online appointment if they want an appointment that way, because often they find that easier than picking up the phone. Or like you said, they're not going to fill in a form. They're not necessarily going to go to an adult for assistance, so they're opening and doing some more work around that. But one of the most important things that they're doing is a youth participation project. So we've put some extra resource in for them to do some co-production with young people to absolutely look at what those barriers are, what stops people from asking for help, what do they want the service to look like, where do they want that service to be. And so that we will be working with a couple of groups of young people, those that are currently engaged and those that aren't, more importantly, to find out what those barriers are so that we can look at the service model and how we need to keep changing things moving forward to get more people accessing.
Thank you very much. Any other questions or comments on this one? Barbara.
You mentioned that the uptake of Hep B vaccinations was falling. I just wondered if you could tell us a little bit more about why that is and what you're proposing to do in order to try and increase the uptake.
Yeah, so to clarify that, so that was Hep B uptake amongst people who are using drugs as opposed to sort of generally across the system. I don't have the specific sort of details on that at the moment. I'll look to Sam just in case there's anything further that you would like to add around that point, but otherwise we might need to follow that up and come back to you.
Sam, do you have anything on that?
I was just going to come in to say we do absolutely need to go and look at the data in that in a bit more detail as part of the recommendations and the follow-up from the HNA. But I think my initial looking at it has dropped slightly, but I think it's one of those things, it's potentially a data issue rather than in reality that the numbers have dropped hugely. And I think it's also with this type of data, we've been concentrating very heavily on Hep C and the take-up of Hep C vaccinations and testing, and sometimes that takes emphasis away from other forms of testing, but we'll be looking into that with our community treatment provider.
Thank you. Right, thank you very much. Sorry, Kate.
Could I just add one thing on the children and young persons discussion? Of course, always we try and take a prevention approach as well. And there is a service that goes into schools and just talks generally about risky behaviours and engages with children and what risks they're choosing to take. And within that, one of the aspects covered is drugs and alcohol use. And it's a way to just get the children to start to understand the impact that might be having. I think we do recognise that this service needs a review. But bringing in all of these aspects and that prevention approach is part of that. So helping with the awareness.
Thank you. Right, so we're recommended to note the activities and outcomes of the Oxfordshire Combating Drugs Partnership reflected in the annual progress report in other papers. Is everybody happy to support that recommendation? Thank you very much, Tom and Sam, and everyone else involved in that report. Right, the next few items on the agenda are verbal updates, 2 from Kate and then 1 from Michelle. And I would just point out that we have 42 minutes of the meeting remaining, and a report from Health Watch and partner boards to come after those items. Kate.
Thank you. So my first item is on the health and wellbeing indicators and a review of the indicators. So the health and wellbeing strategy was launched in 2024, and along with that were a set of indicators and outcomes to help monitor that. As time has gone on, I am increasingly getting feedback from partners that they're finding some of those indicators are now obsolete or difficult to find data for, or aren't necessarily reflecting the work that's going on at the moment. Also, the list of indicators is extremely long. So I am going to lead some work with the Public Health Intelligence team and with the Performance and Insight team to review those indicators and then bring that back here. And I am going to focus on it being a far more succinct list of indicators. So when I'm asking people to do reports on the health and wellbeing strategy, on the particular priorities in the strategy, there's an overarching outcome that they are reporting on, and then able to provide more process and more outcome indicators behind in the report that supports where that's got to. And I'm going to align that with Marmot outcomes, so addressing inequalities. So for each of our priorities, then have an inequalities split on those. So that's my proposal for the next way forward. I will bring back a written report on that, probably in September, I would say, to give us time to actually work through that.
Thank you. Any questions or comments on that? And if everyone is basically in agreement, that's fine, and we can agree that, and we'll move on to the next item.
Okay, thank you. So the next item, I'm going to see if I can share some slides. Hold on. There we go. So this is an update on the Marmot work. I am going to briefly give an update on some of the particular actions that we've been working on, but largely pass over to Veronica to give us an update on the rural inequalities work. So just to remind us, there are three kind of key lines of inquiry we are taking this year, and that's to develop a social movement for understanding the inequalities. For example, having training, making sure people have access to the right data, and having tools like health impact assessment tools, health inequality impact assessment. And that links also to the Director of Public Health annual report with the bank of examples of community projects that have been delivered which are addressing health inequalities. The second line is working with partners on these Institute of Health Equity deep dive recommendations and reports. One of those is very mature. The next one has just started, and I'll give a bit more detail on that. And then thirdly, engaging with residents and the voluntary sector. So just to give an update on the projects that we have been working on. First of all, fair employment. There's another slide coming on that, so I won't dive into that. The Best Start in Life report. This has been presented several times at the Health and Wellbeing Board, and the outcomes from that. The anticipation now is the actual report will come to the July Health and Wellbeing Board in its form where it can actually be published, and then will be published. But in the meantime, we are working with system partners on the recommendations, and in fact are progressing some of that next week to make sure that all of those recommendations are pulling in the same direction. And a lot of that relates to what you were talking about, Councillor Gall, in the Best Start in Life plan. Then the rural inequalities work is about to be presented by Veronica. So and finally, from a research point of view, we continue the work with the Policy Lab, and again we have another round of recruitment for the local Policy Lab of 16 postgraduate fellows covering different projects around those key Marmot principles that we have chosen, which is children and young people, best for the best start in life, fair employment and all for fair employment for all, and healthy standard of living. And so further report will come on that at a later stage. Those projects will be worked on in June and July of this year. From the fair employment for all point of view, this is the next topic for the Institute of Health Equity to work on a deep dive. And at the end of April, we worked with business leaders in a roundtable event to start to understand some of the challenges that they are feeling in providing fair employment and addressing inequalities in employment. It raised some really interesting points. So, for example, feeling that, you know, asking for particular GCSE grades was a barrier, and whether we could have a local kite mark system instead, being able to really access those school leavers and having those links with schools, and being able to make sure that people living in more rural areas can really access the work that's available. So there's a number of actions that we have just started to work on with the Institute of Health Equity, and they're working with those business leaders to see where we take that. So we'll provide more input on that as that progresses. So I'm going to pass to Veronica now, who has worked on understanding the rural inequalities in Oxfordshire. And these are some early findings from the work that you've done. So if I pass over.
Chosen on the basis of the data that was provided, partly census and drilling down to household level, where pockets of deprivation were identified or health inequality were identified. Having said that, this piece of research is a very top level, I would say, initial dive into these areas to speak to people about some of the challenges that they're facing in there. We brought in Community First Oxfordshire to work with us. We've worked together before, and we've both got sort of strong links to the networks across. And there was the steering group for the Marmot group, which brought in the district authorities officers who've been really helpful in helping us access some of these communities. So next slide. Yes, so these are the areas we focused on, 14 different areas spread right across the rural footprint of Oxfordshire, some on the borders with really varied identities about belonging to Oxfordshire, partly because they're on those borders looking over to, say, Swindon or to the Reading area as well, with the example of Watchfield facing Swindon way and Sun in Common facing the Reading way. And so the next slide. Yes, so our engagement took place from January to March. We worked together with Community First Oxfordshire, but we divided it up to, across the geography. So we took the different areas, but using the same methodology. A survey was developed with the steering group pretty much on the lines of the community health profiles, but also with some input from the Institute of Health Equity as well. Quite a far-reaching, rather long survey, but tackling, asking people about all sorts of, their happiness living there, what the challenges were in particular around health, housing, employment, and those sorts of wider determinants. We pushed this out online, social media, through networks, through local newsletters, but very much out on the ground as well. So working again through local introductions, parish clerks, neighbourhood schools and so on to really get this out. And we also did some door-to-door posting of paper surveys. We offered paper surveys. We translated some surveys into Ukrainian as well on request. And then we also just did street work out on the streets, talking to people. And we ran focus groups in each of the areas to have a bit more of in-depth conversations. We also had a second survey which was asking organisations that might work county-wide or within those areas, charities and statutory organisations, to feedback their perspectives. Yeah. So the survey results we heard from over 700 people, and I think the question about rural was not always seen. People don't always see themselves living in these rural areas, because Chipping Norton, for example, and Farringdon actually really are quite significant towns now. But I think we saw that they are hubs to the surrounding rural areas. So next slide. Yeah, huge amount of activity and assets which we've been mapping in these areas. Really strong community-led networks, activities, everything from sort of allotments, you know, WI, the usual sort of thing, but also school-based groups and young people's groups and that sort of thing. People really value living in rural areas. They talk a lot about the green space, the access to green space, and also that sense of community. But of course, within these areas, some people will feel very connected and others will be isolated. And I think what comes out strongly is you know, different people at different times of their life might be more connected or less connected. And when you start maybe having health problems or getting older and having problems with old age, that you might become more isolated. Transport came up really strongly, as we know. Just lack of connectivity, for example, speaking to a group in Watchfield about accessing the GP in Wantage. Stanford in the Vale, that was Wantage. You know, the bus will drop someone in the town square. It doesn't drop them at the GP surgery. So if you're disabled or a wheelchair user, for example, you can't really get very easily to that GP surgery. So next slide. Yeah, I've touched on what people like about that. That came out very strongly. We talked to people about what keeps them healthy and well, and you know, we've heard all of this today. Those connections, social connections, are so important. Exercise, walking the dog, sense of belonging and contributing. Next slide. Yeah, we did hear quite a lot about the cost of living and the impact of the cost of living. We came across people talking about food poverty, particularly exacerbated by access to healthy food, car, you know, having to travel by car to a lot of areas. We heard a lot about potholes, road conditions, but you know, that's one we hear about all the time. But when you actually dig deep and hear that people having to travel miles around sort of areas to avoid, for instance, flooded roads, you know, you hear about that impact on sort of being able to access work opportunities or taking your kids to school and those sorts of things that are, you know, it has a big impact on people's lives. Yeah, a lot around sort of access in the villages or areas themselves, state of pavements, lack of street lighting, that sort of thing. And I think a huge issue again around local new developments and the connectivity between the old settlements and the new settlements, and more needing to be done around how to really plan so that that's integrated across. There's lots more. I won't go on now, but the report will is in draft form for early June, and then I think it's going to Health and Wellbeing Board in September. So we're really at the very early stages of analysing quite a hefty amount of data at the moment.
Thank you both. Any questions or comments on that? Oh, you've taken my firm chairing comments to heart. Fine. Thank you very much for that. Really useful. And more to come. The next item, then, item 13, neighbourhood health plan update from Michelle.
Yeah, no, thank you. And also Chris is going to come in and just talk about neighbourhood health centres and the innovation, the outcomes of the innovation fund. So I'll start, and I just sort of continuing on from the last update that we gave the board. I think people need to understand that the neighbourhood health and care is essentially a new model of care and is becoming broader and broader as we move forward. The neighbourhood framework is now out, which I think if many people have read, it is quite NHS focused, and ANSAF is very much, as is Kate, in ensuring that we include the wider determinants of health, because you know, I think we're all fully cognizant if we don't do that, we will have really missed the point. But I think it's important to note that within the neighbourhood framework, I think there's sort of, if you consider it at 3 levels. So there's the INT level, the integrated neighbourhood teams, which is asking us to focus on very specific groups of people with quite complex health needs. So people, as Councillor Hannah talked about, people who need end-of-life care, people who are very frail, and people care home residents, so have quite complex health needs. Then the second level is more about pathways and becoming much more joined up care, moving from you know, self-care, including the voluntary care sector, moving all the way up through a pathway up into the hospital, and including prevention as well within that pathway. And then coming down to neighbourhood. Now, I think we've all talked about how neighbourhood is quite an unfortunate term, but we are where we are, and we do need to use the terms that we've been given. But I think we need to understand that a neighbourhood should really just be seen as a geographical area, an area that we can actually look at with population health data, and also look at the things that matter to the individuals, as Veronica has very eloquently talked about, things like education, transport, access to healthcare. People living within that neighbourhood will all have common interests in a number of those things. And then when you look at the data from the area, there may be particular projects that actually people might like to focus on, to work together. Now, I spent some time in Didcot, and they have obviously been doing that for quite some time. They've got Healthy Didcot, they have the board, and they've actually, you know, got a really good structure there that I think demonstrates its neighbourhood working. That's the ask. Probably the only thing that perhaps the addition to that would be perhaps a little bit of health input, but I think it's really important that we don't actually disrupt the really good work that's going on in communities. I think when we went and spoke to the people in Didcot, the real message that came up was, do not come here and create something shiny new over there and disrupt the good work that we've done over a number of years since we talked about Sure Start and how communities have come together, particularly the voluntary care sector, to replace the services and the holes that Sure Start left behind. And so it was really, you know, the ask was, yes, we want to work with you, but work with us and identify needs together and develop a project plan. So I think, well, as we move forward, particularly in the neighbourhoods, you know, it's developing a good governance structure, and I think Didcot has got quite a blueprint that actually would be worth the board just looking at, and maybe that's something that we could replicate or show to areas that actually this has been done here, this has been very successful, and perhaps, you know, that's a starting point that people might want to then bring into their areas as we start to work together. And I think what we really need to, although we are looking at population health data, I think it's really important that as we work with communities and also people with complex needs, that we have to have the ethos about what matters to that person, not what is the matter, because the two are very different. And I think we organise a lot of our services around what's convenient to us, and we don't actually think about what works for you know, the people that live in those communities. So as he said, we've been very lucky, and we've been allocated a good bit of funding, which we are going to be using to develop sort of a more organisational framework to support the development of the neighbourhoods. And then Chris is going to come on and talk a little bit about the innovation funding and how that's been allocated. With regards, you know, things like frailty, colleagues who worked in Frimley, and then now the East Berkshire component of Frimley has now come into Thames Valley, had developed a very good frailty model, which has had quite a significant impact not only on admissions, but also it has very good feedback from the people that have been part of that pathway. And that involves, you know, things going from self-care to the voluntary care sector, to primary care, ensuring people have care plans and medication reviews, and then using the virtual wards, which can be used to not only prevent admissions, so so-called step-up care, but can also be used, importantly, to step-down care as people come out of hospital but still need a bit of support. And they also have a remote monitoring platform, which I think the ICB is sort of looking at as well. So there are programmes of work starting to develop. There's another one that we're looking at for children and young people, and we're working with Lisa and her team with the work that they're doing with schools, but also with the family hubs to ensure that we try and don't develop these services in isolation. But I would say that then takes time, and the building of relationships and the change in culture that needs to happen. So I'm happy to take any questions, but Chris might want to give an update first.
Thanks, Chris.
So yeah, I'll just touch on three things. So the first of which is the Thames Valley Innovation Fund. So that was a process that was launched around January time, looking to allocate a relatively small amount of funding when compared to how much we spend on healthcare across the Thames Valley. But we did have some flexibility with where some additional growth funding would go. A set of decisions has been made recently which will result in some allocations coming to Oxfordshire, which we will use our existing infrastructure and oversight arrangements to kind of further spec up and allocate. But the delivery areas relate to establishing children and young people's multidisciplinary teams. So this will support again those children and young people with several vulnerabilities and complexities. So bringing together primary care, secondary care, and voluntary sector and social care. So ultimately, it will fund time of individual professionals and practitioners rather than establishing something separate and in addition to. Alongside that, we will also be allocating some funding to some of our most deprived areas again, so looking at the continuation of our community health wellbeing workers in Oxfordshire, which are really targeted at a street level, so one worker covering around 150 households. So that delivery currently takes place in Barton and Littlemore, and for the remainder of this year we'll be able to continue that, and then in future years look to roll out into other targeted areas. But the intention of that is not to have full coverage across Oxfordshire, it's a really targeted intervention. Third area is on frailty integrated neighbourhood teams. So this is what Michelle referred to in terms of complexity and vulnerability. So again, this is targeting some of the highest consumers and typically people that require multi-organisational responses. And then the final area of the Thames Valley Innovation Fund relates to CVD prevention, and early thinking to date would be to continue our physical activity programme that we have in place in Oxfordshire, and also build on some of the existing health check outreach programmes, and also think about how that links with community capacity that Erica was speaking about in terms of Well Together. So it may be that that sort of infrastructure and the organisations that have worked on Well Together would be well placed to support that. So that's the first area. The second area relates to neighbourhood health centres. So I'm conscious that many local authorities and other organisations may have received correspondence in regards to neighbourhood health centres recently. The ICB has been asked to develop a draft pipeline for what neighbourhood health centres could look like across the ICB footprint. Obviously, Thames Valley is large and vast. So in Oxfordshire, we have now established a bit of a group with officers from county councils, city and districts, Oxford University Hospitals, Oxford Health, and the ICB to try and pull together a first draft of what that pipeline looks like. I think worth bearing in mind the kind of the scale and ambition here, whereby central government in the autumn budget outlined 250 neighbourhood health centres by 2035 off the top of my head. So we're not looking at wide scale here for Oxfordshire. It would be a small number, but we are looking at what those, in all likelihood, existing sites and what the repurposing of those would look like. It may be that there are opportunities for new sites, but I think we certainly need to look at what we currently have. That also leads to a wider conversation about one public estate type approaches and how we can use space more collaboratively and flexibly. But there is a specific ask around neighbourhood health centres as per NHS guidance, which is admittedly rather clinical. And then the final area relates to some structured system reviews. So the ICB will be participating in structured reviews with NHS England's national team. So Dr. Claire Fuller and team will be visiting the Thames Valley on the 23rd of June to conduct what is not being framed as an assurance visit, but more a support visit. So again, we have good representation confirmed from relevant organisations in Oxfordshire, so namely Oxford University Hospitals, Oxford Health, Primary Care, the County Council, City and Districts, and also the voluntary community faith and social enterprise sector as well. So that will take place on the 23rd of June with a return visit 6 weeks later as well. So we'll feed back anything relevant to the board as required.
Thank you very much. And thank you, Michelle, for acknowledging the ridiculous name of neighbourhood health plans and centres, which are not neighbourhood health plans or centres, and is already creating huge amounts of confusion, because I'm sure other councillors have found the same. We're getting lots of requests now for a new neighbourhood health centre in the neighbourhood. So that's, yeah, very telling. The other point I just want to pick up on what you said is in Oxfordshire, roughly half the population lives in or around a large town. And that actually is the footprint on which most people would identify with. So any learnings that we can make from what's happened, from the approach in Didcot, or indeed anywhere else in the county or elsewhere, that can help us move in that direction, I think would be really positive. And that's maybe something to pick up on going forward. Does anyone have any questions or comments? Councillor Pickhills.
Yeah, we're talking about Oxfordshire neighbourhoods, aren't we? But as you know, there is a corner of the Vale which is Oxfordshire for education, for social care, but for health is part of the Baths, Wyndham, Wiltshire ICB. And as we as council have asked them, you know, what are your plans relative, you know, what are your plans compared with what's happening on for Oxfordshire? But I just wondered how are you working with them? Because there is going to be an overlap, isn't it? Although they're looking that way for health and this way for everything else.
I think it's similar for all places on the border. So similarly down in the southeast that face, West Berkshire, for Tame, that's moving into Buckinghamshire. So we know, and then there'll be places in the north that are going into Northamptonshire. We know these are areas that it's historical. We know there's issues with discharging, coming across the border. So I think those are things that we will have to, work through and understand what the problems people face and then how we work through solutions. But I think a lot of those issues are quite historical. And again, it'll be a case of, what really matters to that community and the residents. I think that's been the real strength of the model in Didcot, where they have Healthy Didcot, which is chaired by someone from the Patient Participation Group, and they get the voice of the community to feed into what, the areas that really matter. So I suppose they'll just work through those, but we do know there's different difficulties. I think that there's meetings going on about one border area, and we'll have to work through those one by one.
Thank you. 12 minutes to go. Any other questions or comments on that report? No? Okay, so thank you very much. We're asked to note the neighbourhood health plan update. So we all agree to note the update. Thank you. Moving on to item 14, which is a report from Health Watch Oxfordshire, which I'm assuming is Barbara and Veronica.
Thank you. I think building on the theme earlier this morning, we heard a lot about the community health approaches. That's what I want to highlight in our report today. We've done our bread and butter reports, for example, on Cora Health, which is the MSK services. We've just published a report on GP services on what we've heard. All of our engagement is via lots of different pathways. We're hearing from people through, which is online, through phone calls, through being out and about, very present across the county, as you've just heard from me speaking about the rural engagement as well. So we're out on the streets, and in community settings. We've produced a summary of what we heard from speaking to men on the streets in Farringdon as well. But our community research approach that we've developed since probably 2018 is very much about working alongside and with communities to hear about what's important to them. And that is a long process. It's a process which communities feed into and often do the research with us, alongside us, together. So we've, just to highlight some of the pieces of work we've just published this week. We worked with a member of the Chinese community who did interviews with across elderly Chinese members of his area, and hearing still about very entrenched challenges to accessing healthcare and understanding and navigating healthcare, and the language barriers there. We also have published our report on work with the Sunrise Multicultural Centre. Again, that was community-led research focused on cancer. I've got a summary here if anyone wants it. And that's working with women, talking to them about their barriers or concerns about accessing screening, for example. And we brought in a breast nurse to work with them and do a bit of education on that as well. And then again, we've just published working with a group which was partly funded by Well Together, Black Women in Maternity, a group of African, Caribbean, African heritage women in the Leeds area, focusing on some of those persistent barriers to trust and engaging with maternity services and some of the outcomes there. So what we do next often is we'll bring health professionals together with those groups to talk through what we've heard and get that development of dialogue. But I think really what I want to talk about today, because this has been launched today, I'm really proud to sort of introduce this. It's a wonderful visual handbook that we've produced, partly funded through a series of workshops that we held in the autumn with the Oxfordshire Community Research Network funding via Oxford University. We ran three workshops from September to December, bringing in about 25, 30, it sort of grew as we went along, of the very grassroots, global majority, but also other groups. So we engaged people, the Nepalese or Gurkha Society, African Caribbean, African Heritage groups, Oxford Community Action, the Neighbourhood Plan group, and the Lived Experience Advisory Forum, which is the homelessness lived experience group. So we worked through developing this how-to guide for community research to support that community research approach and make it more accessible and available for any of these groups that might want to, patient groups, youth groups, others who might want to do community research themselves. And it's here anyway. This is available on our website to be downloaded. It will be available for anyone who wants to have it on their website. But it's a really engaging document. It's been produced, it's got the voices of the people in that, it's got examples of Oxfordshire's community research approach, and it's got workbooks and worksheet questions, and it takes people through the steps of community participatory research. So that's, I'm just bringing that to the group today, but I think really encourage all of you within your own networks to make that a real thing. And I think it ties very well into the discussions on neighbourhoods and how we're going to move forward with engaging those voices into the development of a neighbourhood health vision as well. Yeah, so that's probably all I want to mention here. We will be running with community members a community marmot event again in June. So.
Thank you very much. Barbara, do you have anything to add? You don't have to have.
Not really. I think Veronica said everything that we need to say, but it just shows you, just the depth and breadth of the work that Healthwatch Oxfordshire does.
Yeah, thank you. Any questions or comments? I'm not seeing anything. I would just like to say thank you very much for your continuing excellent work, giving patients a voice, giving people a voice in the health system. Sorry, go ahead.
If I could just briefly come in now that we're speaking of patient voice, just to update the board that the Independent Patient Voice Working Group has held a meeting early last week to discuss both the material that will be used as part of the engagement exercise to explore what a future patient voice will look like, as well as a potential mapping exercise to look at where patient voice functions already exist in the system and how to avoid duplicating those. So that work is still ongoing in the background. You will have noticed from the King's speech yesterday that government is adamant on pursuing its original plans to abolish the Healthwatch function. The legislation hasn't yet come out, so we cannot definitively, or the working group cannot definitively make any concrete recommendations to the board to make a decision about any future local patient voice, although there is definitely an indication as to the direction that we're heading towards. But the working group will update the Health Wellbeing Board accordingly with a report in a future meeting as well.
Thanks. You successfully preempted the rest of my comment, so that was excellent. Well done. Probably said it more coherently than I would have done. Right, thank you very much. So we have received and noted the Healthwatch Oxfordshire report on patient views and experiences of Oxfordshire Health and Care Services. Thank you very much. And the final item then is a report from partner boards. We have two on the agenda, the Oxfordshire Place-Based Partnership and the Children's Trust. And at our pre-meeting, we weren't certain whether the Children's Trust, I think, had met since our last meeting, but happy to hear brief updates on either or both of those.
Minimal update from place-based partnership, I think a lot of the content in relation to neighbourhoods and the Better Care Fund plan were spoken to at length today. I think one thing that may be worth stating on behalf of the recently formed Thames Valley Integrated Care Board, we have commissioned an independent review of our joint commissioning and integrated commissioning arrangements across the 8 local authorities that we work with. So that engagement started earlier this week and I think is intended to go on for 6 weeks in total. So we will receive some observations and recommendations as a result of that. I believe officers related to that have been made aware as well. So we will again feedback anything relevant to the board.
Thanks very much, Chris. Councillor Gall.
I have a very extensive update. No, so the Children's Trust Board is in a very good place. I'm really excited about the work that is currently undertaken, and the thing I'd just like to highlight on behalf of the Children's Trust Board is, you know, we highlighted something that we wasn't happy with, which is the good level of development for our free school children. And the government's target was going to be 50%. We've said we're going for 60% off the back of this commitment, off the back of a very good plan that is being written. Considerably more Oxfordshire children will start school ready to learn because of this work that we've all collectively been contributing and working hard towards. So I'm very excited where we are currently. Thank you.
Thanks very much, Sean. So the final item on the agenda then is for us asking for us to note the forward work programme. Kate or Ahmed, is there anything you need to add to what's already in the papers?
The only thing, Kate, I might emphasise, and correct me if I'm wrong, is that we will not be having the item on climate impact on health at the next meeting because we simply do not have enough time to have a report produced for that for a meaningful update. But I think all the other items on the agenda, on the all age autism strategy was coming for sign off, on the marketplace update, on the health wellbeing strategy indicator review, on prevention of homelessness directors group update, and on the neighbourhood health plan update will be coming. But I think the indicator review will probably be a verbal update.
Yeah.
And I think we will be having a report from the Institute of Health Equity for the marketplace item.
Thank you very much. So we're finishing. It's 3 minutes late according to the time on the speaker, but exactly on time according to my laptop. So I'm going to take that. Thank you very much for your attendance and participation.
Is the board happy to delegate? Sorry. Me and Kate Holborn to make any tweaks to the forward work plan offline if need be.
They're enthusiastic. Yeah. Thank you. Thank you very much, everyone. Nice to see you all.